Hello, I'm Graham Syers. I'm a GP in Alnwick in Northumberland. I've been asked to answer a few questions to help the citizens' jury think about a number of points. I've worked as a GP for 25 years. I've got quite a background in musculoskeletal and prescribing and pain medicine. First question is, what's a biopsychosocial model of pain? What are the barriers for GPs in applying it? The biological part of that is all to do with what's the cause of the nature of the injury originally? What was it that happened to cause my pain, and how should we treat it and fix it? A psychological aspect of pain would be much more about what frame of mind am I in that will affect how I react to my pain. So you can imagine people who are depressed, anxious, post-traumatic stress disorder, things like that, they will behave differently around their pain. Also, any existing mental health disorders like autistic spectrum disorder, ADHD, also have an impact. What about the social aspects, the biopsychosocial side? So what's my current employment? What's my living situation? What stresses am I under in life, which will impact on my ability to do things or other? Am I on benefits? All of these things encompass and interact with each other about how pain is. The barriers for a GP in applying that are that sometimes patients expect us to be very medical in our approach. They expect investigations and a diagnosis and an answer to what's wrong and a solution and a fix. And that can make it difficult. The other thing is to have a true biopsychosocial aspect. We need to have time and trust and a relationship with our patient and continuity to allow that to happen. What do patients expect and demand? Uh, uh, I think patients expect to be listened to, and we need time to allow ourselves to do that. Sometimes patients do expect fixes. Sometimes they feel nobody has taken the time to listen. Sometimes they feel that they've been fobbed off. Sometimes they feel if we take a biopsychosocial approach, they don't really understand what we're trying to achieve in doing that. Why are you not giving me a prescription? Why do you not believe the amount of pain I'm in? Why are you not giving me stronger analgesia? So that can be quite testing at times. And it's not uncommon for a patient to leave and feel dissatisfied if the GP's just not quite got the level of communication correct. It can be quite stressful for both parties sometimes. What changes would I like to see in managing persistent pain? I think if we can move away from the expectation of always being able to find the root cause. Now, obviously, if you're asking somebody to live with a persistent pain and that there won't be a solution, well, why have you not done a scan to the nth degree to tell me that there certainly isn't something that could be fixed? So that expectation about to be fully investigated and have all the diagnostic procedures, as a GP, the last thing I want to do is overlook something or miss something. And therefore, there is a tendency sometimes to over investigate people. And in the process of doing that, the whole thing becomes quite medicalized. The patient becomes a passenger. The patient becomes passive. Tell me what I must do. Tell me what you're going to do to fix me. Whereas a different conversation would be, well, what could you do that would help? How can we get you moving better? How can we approach the social difficulties that you're having? Is there a way of helping with your housing? Is there a way of helping with the debt problems? What about the benefit system? How are you navigating that at present? So having a much more, we would call it holistic approach to people. And I think that does mean thinking about pain as a long-term condition and not something which will be fixed, and having a slightly different team of people that can support. Um, how can GPs recognise when patients may be on a bereavement pathway due to persistent pain? If you have a terrible pain, you will have a loss for the ability to lead the life you used to live. That's no different from being bereaved of a close relative in terms of the psychological response. So with loss often comes the first thing is denial. It hasn't really happened. I'll continue the same. I'll pretend it's not happening. Often alongside that comes anger. Why has it happened to me? This is not fair. This is unjust. Somebody's to blame. And if you externalize the cause of your persistent pain, it's much harder then to get the responsibility to live with it back internally. Sadness, loss, emptiness, hopelessness. These are all emotions which will often come to somebody who is suffering from persistent pain, no different to having bereaved of a relative, a loved one. And then finally, resolution or acceptance. So, usually for somebody who's been bereaved, life will eventually move on unless you get stuck. An abnormal grief reaction might be that you get stuck in the emotion at some stage. And this is why sometimes behavioral therapy, counseling can be really helpful for people who are trying to move through the process of grief and bereavement that comes with persistent pain. But if we can get people to move to an acceptance of life will carry on, but I will not be the person that I was before, but I can do things despite that. And that's where we need to try to get people to. Hope that was interesting. Look forward to seeing you and speaking to you at the panel. Thank you.